Good afternoon, everybody, and welcome to Citywide Medical Grand Rounds for today, which is January 11th, 2024. I'm Dr. Madeline Verhofsek. I'm the Chief of Medicine here at St. Joseph Healthcare Hamilton, and pleased to be the host site for today. Next slide, please. So we'll start with a land acknowledgement, which is an important part of each week at Medical Grand Rounds. We'd like to acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and the Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Next slide, please. I want to also recognize that many people are suffering right now in light of global events. This collective grief has led many of us to reach out to colleagues to check in on their individual well-being and that of their loved ones, and to offer support. Many people are deeply hurting right now, and I would like to invite us all to strive to recognize our shared humanity and the profound importance of continual pursuit of mutual understanding in our academic healthcare environment with a goal of peace and human rights for all. Next slide, please. With all of our welcome to our attendees today, I'm delighted to also welcome our two speakers. So we have Drs. Tim O'Shea and Robin Lennox joining us today. They are both the co-heads of service of the Citywide Substance Use Service, and they are here to share with us on the topic of improving the care of people who use drugs in hospital, challenges and opportunities. I'll provide a little bit more background about each of them, and then I'll hand it over to them to to present to us and share this important information. So to start, Dr. Robin Lennox is an assistant clinical professor and a family physician with the Department of Family Medicine at McMaster University. She has a clinical focus in the care of people who use drugs, and as mentioned, is the co-head of service for the inpatient substance use service, both at St. Joe's and sharing that responsibility over at SJHH as well. Dr. Tim O'Shea received his Bachelor of Science in Biomedical Sciences from the University of Guelph before completing his medical degree at McMaster and a Master's of Public Health at Harvard University. He trained in internal medicine, infectious diseases, and medical microbiology at McMaster and is Royal College certified in these disciplines. He's currently an associate professor in the Department of Medicine, Division of Infectious Diseases, and he's served as an internal medicine consultant for the Shelter Health Network in Hamilton and for Refuge Hamilton Center for Newcomer Health. He's currently the medical director of the Hamilton Social Medicine Response Team. So again, we're so grateful to both of you for joining and for preparing this talk for our audience today. And I'll hand it over to you.
Thank you, Dr. Verhofsek. So I'm the lead-off hitter today, and Dr. Lennox is going to be the one to bring home the presentation at the end. So jumping right into it. So thanks for the introduction, and thank you to all of you for joining today. This is our conflicts of interest slide for you to peruse, and then we will jump into the presentation. As mentioned in the title, what we wanted to do today was to talk a little bit about some of the challenges associated with caring for people who use drugs in the hospital environment and some opportunities that we see for improvement in that care. We're going to start with a case today, and if we look at the news in Hamilton, the news across Ontario, and the statistics from public health, we know that this is a case that happens probably daily in the emergency departments in Hamilton, or cases similar to it. So Lee is a 27-year-old woman who was brought into the emergency department by the paramedics after she was found with a decreased level of consciousness and respiratory depression in the community. The paramedics administered naloxone in the field, and then she was brought into the emergency department for further assessment. After the naloxone administration, her respiratory rate and oxygen saturation improved. but she remained to have a decreased level of consciousness for several hours, which after her urine drug screen came back was attributed to likely benzodiazepine contaminated fentanyl supply. Given the prolonged decreased level of consciousness, she was referred to the internal medicine team. She was assessed by the residents overnight, and then her MRP met her in the morning, at which point her level of consciousness had improved to baseline, and she was considered appropriate for discharge. On the assessment of her MRP, Lee disclosed that she had been using about 1 gram of fentanyl intravenously daily for the past 2 years. During this time, she'd had multiple attempts to engage in care with the goal of reducing or eliminating her fentanyl use. And she'd had multiple trials of buprenorphine naloxone or Suboxone, which ultimately proved to be unsuccessful for her. Given her past history, she declined an offer of a Suboxone start in the emergency department, but she did express that she was interested in starting methadone. The MRP decided there was no other indication for admission, and so the patient was discharged with a referral to the RAM clinic and was given a take-home naloxone kit from a harm reduction perspective. So like I mentioned, a very common case. We know that people with opioid use disorder and with substance use disorders in general present to the hospital often. We know this again from research, but also just from our day-to-day experience. The numbers show that people who have opioid use disorder have rates of emergency room visits about 7 times those without, and have rates of hospitalization about 8 times those without. Reasons for visits to the emergency department or for hospital admission include opioid toxicity or substance toxicity. Oftentimes, patients present with complications from trauma. And then as well, a common indication for admission or visits to the emergency department are infectious complications, particularly those related to injection. With these frequent interactions with the hospital, there's often a degree of fraughtness to the relationship from the patient as well as from the caregivers on the hospital side. There are many reasons for this overall, not all of which are listed here on the slide, but some of them include some of the things we've listed here. So in general, a lack of healthcare provider training on the management of patients with substance use disorder leads to a lack of comfort in providing care for people with substance use disorder. And from that, there's oftentimes some tension between the healthcare team and the patient themselves. Certainly over the last number of years, there's been some movement in this in terms of increased availability in the curriculum of medical schools and residency programs in terms of care of people who use drugs, but certainly there's still quite a bit of room to improve this. Hospitals often have policies in place which, although well-intentioned, can make it very difficult for patients who use drugs to exist within the hospital space and to receive care in a manner that feels comfortable to them and doesn't lead to tension or conflict with the healthcare team. We know that there is remains a significant stigma related to drug use, and from this, as well as some of these other factors that I've mentioned, oftentimes patients report a very negative experience when they're accessing healthcare. All of this leads to increased unplanned discharges for patients and the complications that come from that. And ultimately, patients start to avoid seeking healthcare, whether it's in the hospital or other settings, because of the experiences that they've had in the past and fear of things like stigma. This also leads to missed opportunities to address the underlying substance use disorder and other factors that go into the substance use disorder for patients when they aren't seeking care. So as mentioned off the top, we wanted to identify some of the challenges, but also to discuss some areas that we think are available for improvement in these relationships. And we wanted to focus on 3 things in particular. So first off, supporting patients to stay in hospital to ensure that they receive the treatment for their acute medical conditions that they need. And here focusing on making sure that withdrawal, craving, and acute pain are managed well. Secondly, to use hospitalization as an opportunity to initiate treatment for opioid use disorder in particular, using opioid agonist therapy, which we know is standard of care and leads to improvements in both mortality and morbidity. And then finally, looking at ways to mitigate risks that people who use opioids experience while they're hospitalized, as well as when they leave hospital. And under this topic, thinking of things like maintaining opioid tolerance while in hospital, avoiding, if we can, unplanned discharges, but also having a plan in place in case unplanned discharges happen, and always ensuring that individuals receive care that follows a harm reduction approach. So to start off, supporting patients to stay in hospital to receive care for their acute medical concerns, the first thing we wanted to talk about was ensuring that patients' acute pain is well managed. Oftentimes when people who use drugs present to hospital, they're there for conditions that have a component of pain in their presentation, whether that be from trauma, skin and soft tissue infections, bone and joint infections. And oftentimes it's this pain that ends up being a focus both for the patient and for the care team to get a handle on. We know that people who have opioid use disorders often have high opioid tolerance and therefore will require higher opioid doses for their acute pain management. And we want to avoid a situation where we're holding back on opioids, worried about worsening a patient's opioid use disorder, as we know that that will not be the case. And then finally, for people who are on opioid agonist therapy, when they come into hospital, we want to recognize that really the opioid agonist therapy should be seen as a management for withdrawal and cravings, and then recognize that when acute pain comes on top of that, we'll need to come up with a different strategy for management of the pain. So some of the strategies that we use on the substance use service when we're managing patients in pain who have underlying opioid use disorder, really similar to when we're managing pain in people who don't have opioid use disorder, we want to recognize that short-acting opioids are effective, but also importantly can be titrated quickly and easily. So for myself, oftentimes I find it difficult to guess or to calculate what dose of an opioid somebody's going to need for their acute pain, particularly when there's street opioid use happening in the background. And so I think one of the principles that I try to follow, and which we would encourage others to follow as well, is recognizing that we want to balance managing the pain well with safety and making sure we're not overdosing patients. Oftentimes our initial dose is going to be underdosing the patient for pain, which I think in the end is okay as long as we ensure the patient that we're going to frequently reassess that dose. We're going to believe them when they tell us that it's working or it's not working, and we're going to adjust that dose accordingly. And then importantly, following through on that promise to patients and making sure that we're doing those assessments frequently and making adjustments as we need to. We found on our team that a combination of both scheduled and as needed opioids is effective, particularly because patients often feel reluctant to ask for PRNs when that's the only thing that's ordered, because they either perceive or experience actual stigma when they do ask for their pain medication when it's a PRN. Again, with scheduled opioids, we would put on a hold parameter for decreased level of consciousness or decreased respiratory rate from a safety perspective. But overall, this ends up being an effective strategy to make sure patients get the pain medications that they need. And then always, when managing pain, thinking of adjuncts when appropriate. The second part of this is recognizing that opioid withdrawal for patients who have an opioid use disorder is always distressing, can be quite severe, and particularly in patients who are medically unstable or those who are pregnant can be dangerous. As well, opioid withdrawal that is poorly managed is often a contributing factor to early discharge or unplanned discharge, as well as treatment interruptions as patients go off ward or other places to seek treatment for their withdrawal. In assessing opioid withdrawal, we have tools like the COWS score that we can use. But again, we would encourage you as well to be asking patients about how their withdrawal is being managed and believing them when they tell us, and making adjustments based off of that. So patient report is an important component of this. And then overall, looking at a combination of long-acting opioids, which can give a baseline opioid in the background, along with some short-acting, both scheduled and as needed, as an effective strategy overall. A couple of examples are given here in terms of starting regimens for patients who are accessing street fentanyl in particular, non-prescribed fentanyl. recognizing again the high tolerance that patients will have coming in, and the need for fairly high doses of opioids in order to manage their withdrawal and cravings. We know that when we're able to adequately control pain, craving, and withdrawal, patients are more likely to stay in hospital for the duration of their needed stay and receive the care that they require, which ultimately leads to better outcomes, which leads to less trips back to the emergency department in the future to get care, and overall lower unplanned discharge rates. I think importantly as well, when patients' pain, craving, and withdrawal is well managed, they are more likely to engage and collaborate with the healthcare team, which ends up being more satisfying both for the patient and for the healthcare team in terms of the overall experience. And then many, if not most of our patients have had largely negative experiences when seeking healthcare. And so as we start to build up positive experiences, we can start to counteract the overall reluctance to seek care. And patients will then be more likely to come to the hospital or to their family physician or to a drop-in clinic when they need care. Our second main point is looking at ensuring that we use hospitalization as an opportunity to start treatment for opioid use disorder if desired by the patient. So just very quickly going over opioid agonist therapy. So the principles behind opioid agonist therapy, again, are to manage opioid cravings and withdrawal symptoms using a long-acting medication that typically will manage these symptoms for 24 hours as our goal. The three medications we use to achieve this would be buprenorphine naloxone or Suboxone, methadone, or slow-release oral morphine or Cadian. And we know from the literature, some of which Dr. Lennox is going to review in a few slides, that patients who are on opioid agonist therapy and are able to maintain those prescriptions have lower all-cause mortality, have lower rates of overdose, and have a reduction in their non-prescribed opioid use. Despite the very excellent evidence that we have to support the use of opioid agonist therapy, we have a huge gap in terms of implementation of these life-saving medications. A recent survey published in the CMAJ in December of 2023 looked at hospital visits for opioid toxicity in Ontario between 2013 and 2020, and then looked to see how many of those patients were started on opioid agonist therapy, receiving a prescription within 1 week of discharge. And the bottom line is that we're doing a really poor job overall, with only 1 in 18 patients dispensed an opioid agonist therapy prescription within 1 week of discharge. This was out of a total of 20,000 hospital visits for opioid toxicity, and related to 4.1% overall. People that were more likely to start opioid agonist therapy were overall younger, lived in higher neighborhood income quintile settings, were more likely to have had another opioid toxicity episode in the previous year, and were more likely to have been treated with opioid agonist therapy in the previous year, but not in the past month. So I'm going to pause there, and I'm going to hand it over to Dr. Lennox for the remainder of the presentation.
Thanks, Tim. So as Tim was kind of speaking to, so, we know that we're, in the 7th year, going into the 8th year of what's been declared an emergency in relation to opioid overdose deaths across Canada. And we know that opioid overdose are presenting to our hospitals every single day. There were 88 presentations to the emergency department for opioid toxicity in Hamilton in September alone. And we tend to think about opioid overdose as a singular significant event happening to someone, but after that event is treated or dealt with, most often with naloxone and monitoring, we tend to not contextualize it within sort of the continuum or the trajectory of a medical condition that is actually considered quite life-threatening and causes a lot of premature deaths among young people in Canada. And so in thinking about sort of an event like a hospital presentation for an opioid overdose, there have been studies looking at what the mortality rates are for those who have presented to the hospital for an opioid overdose. And it might be surprising to learn that the 1-year mortality rates for folks after having had an overdose are between 5.5 and 8% per year. And that's a significant number when you think that the vast majority of people experiencing opioid overdose who are presenting to hospital are young. So the vast majority are under the age of 40. Many do not have any significant concurrent medical conditions that would contribute towards premature death. We know that most subsequent deaths that do occur are actually due to fatal overdose. And so we're seeing many people experiencing subsequent overdoses over time. 20% of those overdose deaths occur within the first month of discharge after being presented to hospital for an overdose itself. And there is a dose-response relationship between the number of non-fatal overdoses you have and the risk of dying subsequently from overdose. So we see that the more overdoses you have, the more likely you are to have a fatal overdose. And the majority of those deaths are occurring, again, between the ages of 25 and 40, the majority among males, and significant disproportionate amount among those who are unhoused. But we also know that this risk is modifiable. So we know that, opioid agonist therapy alone is one intervention, a medication that is proven to reduce the risk of subsequent overdose death and all-cause mortality. And yet, as Tim presented, we're using it in a small fraction of the patients who are presenting with this concern to hospital. And we also know that the vast majority of folks with opioid overdose are discharged directly from the emergency department. So again, we're not treating it necessarily as a significant event once the acute symptoms tend to be resolving. And so this is sort of in contrast. I'll get you to move the slide, Tim. This is in contrast to rates of death for myocardial infarction. So we see folks coming to a hospital with MI. We recognize it as a serious cardiac event that's occurring sort of in the course of a chronic illness trajectory often, that precipitates, admission to hospital, urgent intervention that's often very costly. We have great multidisciplinary management teams that collaborate to care for people who've experienced MI and coronary artery disease. And we also have specialized follow-up, like cardiac rehabs available to support people after this initial event and their reintegration back into the community, recognizing that, this condition is sort of a sign of sort of someone's instability, that there is modifiable risk, but that their risk of recurrent events remains quite high in the absence of treatment. So for MI, for example, in the absence of adequate secondary prevention, rates of subsequent cardiac mortality are about 10% in the first year following an MI. And similarly to overdose, there is a bit of a dose-response relationship that this risk increases after a subsequent MI. And we know that also that risk of cardiovascular mortality following MI is reduced by the implementation of evidence-based treatment, which is why we have all of these amazing programs in place. And so when you think about it sort of in these terms, an MI and an opioid overdose are both significant events that can occur for someone that can be life-threatening, but if survived, continue to confer ongoing risk of subsequent death from the same condition unless aggressive treatment is implemented. And yet our approach to an MI and our approach to an overdose vary dramatically. So for the most part, for folks presenting with overdose, once their respiratory status is improved, once they're able to ambulate, they're most often going home. And as we've seen in the literature, they're going home without actual treatment for the underlying condition related to that presentation. Go to the next slide. So our proposal is that we believe that we should start treating opioid overdose as both the medical emergency that it is that requires emergent treatment, but also an opportunity for intervention to try to improve the health outcomes and reduce the risk of subsequent overdose mortality following an event. So similarly to MI, we believe that all people who present to the hospital with opioid overdose should be offered a hospital admission for stabilization and treatment initiation if desired. We anticipate that perhaps not all patients would take this opportunity because it is a very difficult place for patients to be. Being a hospital is not an easy environment. However, for those who would be willing to stay for a hospital admission, it could be significantly beneficial. Next slide. Just to show you sort of what a post-overdose hospitalization could offer compared to outpatient treatment. So in the kind of inpatient OAT titration arm, you can see that for folks who wanted to come into hospital, we're able to titrate their opioid agonist therapy much more rapidly to get to a therapeutic dose. So for context, most people with an opioid use disorder using fentanyl will require somewhere between 1,500 and 2,000 morphine equivalents in order to stabilize from a withdrawal perspective. So it's very difficult to get to that dose as an outpatient. In the kind of the right-hand side of that chart, you can see an outpatient OAT titration. That titration assumes that you're seeing a provider who's willing to dose increase to the maximum of the range, and also that you're not missing any doses. So you're getting to the pharmacy every single day, you're going for appointments every 3 days, and you're not missing either of those. So that's sort of the perfect world outpatient scenario, which we know is very challenging, particularly for people who are outdoors, who lack transportation, who are having other significant sort of health things going on. But from an inpatient perspective, we can get someone's doses far, far higher within just a few days than they could likely achieve as an outpatient. Realistically, getting to a dose of methadone 85 milligrams or Cadian 900 milligrams usually takes someone a few weeks as an outpatient compared to a few days as an inpatient. And we know that opioid agonist therapy can have significant benefit for people in terms of reducing their need for non-prescribed opioids and therefore reducing their risk of overdose. Next slide. In addition, while they're in hospital, they can connect with some essential support. So they can be connected to social work, get resources in terms of housing, for example, referral to a shelter or a transitional living program. They can get health cards dealt with, income resources dealt with, all these things that we know that increase someone's stability as an outpatient, but are very difficult to achieve when you have an unstable opioid use disorder and you're living outdoors. They could also, if they're interested, complete a GAINS assessment, which is an Ontario eligibility assessment for bed-based treatment if desired. And we have had a number of patients go directly from hospital, complete their GAINS, and then be referred to an outpatient residential treatment program if that's their goal. And then shifting our response. So if someone was not interested in coming into hospital, although we do believe we should be offering that, we should make sure that every single person who presents to hospital with an opioid overdose is offered point of care initiation of any opioid agonist therapy that is their choosing. So whether it's, Suboxone, methadone, or Cadian, all are evidence-based opioid agonist therapies. Every single person with an opioid overdose should at least be offered these, and we would hope that a majority would have a prescription prior to leaving the hospital with a follow-up plan in place for continuation. As we know, these rates are actually appallingly low, and this is something that we should be trying to implement on medicine wards, in the emergency department, at every opportunity for point of care starts that we can. Next slide. And in terms of the evidence for why opioid agonist therapy is so beneficial, so in the 12 months after a non-fatal overdose, being prescribed opioid agonist therapy significantly reduced all-cause mortality. So it reduced all-cause mortality by 53% for those who are prescribed methadone and by 37% for those who are prescribed buprenorphine or Suboxone, and also reduced opioid-related mortality by 59% for methadone and 39% for Suboxone. And these results even hold up in the fentanyl era. So prior to the fentanyl era, when, opioid tolerances were quite a bit lower, when people were using, primarily oxycodone, hydromorphone, or heroin, the thought was, are we seeing less benefit now because the potency of the street supply of opioids is so much higher? And it's actually the opposite. So we see the benefit has only increased in the fentanyl era, so that the relative risk of all-cause mortality for people who are off opioid agonist therapy is now 3.4 times higher for those than are on opioid agonist therapy. So we know that this is a benefit. We know that the importance is only getting greater as the supply is getting more dangerous. And then for all people who present to hospital with opioid overdose, we should be doing sort of other secondary prevention, like counseling on overdose prevention strategies. So these can include simple, talking points that you can do upon discharge, like, try not to use alone. We know that 75% of opioid-related deaths in the community had no bystander present to call EMS or to administer naloxone. So at any option, using among others can be a life-saving tool. Always having take-home naloxone kits, which are available free of charge from any pharmacy and many harm reduction dispensaries. Using in-person or virtual supervised consumption services, and I can speak to that on the next slide. Using a test dose of substances. So, from Toronto drug checking data, we know that in the most recent samples of fentanyl or expected fentanyl samples, the range of actual fentanyl in those drugs ranges from 8% to 80%. So you can imagine that if your supply is changing week to week, and you're used to an 8% concentration sample, and then the next sample you get is a 50% concentration sample, your risk of overdose using the same amount is going to increase. So with every change in supply, using a test dose to kind of assess tolerance and then avoiding mixing opioids with benzodiazepines or alcohol. That's very difficult in this era of street fentanyl, which is often contaminated with street benzodiazepines. So someone doesn't intentionally mix, but it's in their supply. But if possible, trying not to add in any other sedating substances when you can. And then in the next slide, so these are virtual supervised consumption services that are free and available Canada-wide. And I think all providers should just be aware of them so that we can refer our patients to them. So one is the National Overdose Response Service, or NORS. So that is a 188 number where you can call from anywhere in Canada 24/7. Someone will be on the other line who is most often a peer worker or someone with experience using drugs, who will stay on the line with you and kind of continually prompt you. And if you became non-responsive while using on the phone, they could send EMS or enact a safety plan. Similarly to that, but requiring less sort of verbal interaction, is the Brave app, where you can download this app, again, free of charge. Privacy data is protected. You can input a rescue plan, and someone on the other end will be monitoring, and you have to kind of continually tap and respond. But if you become non-responsive, they would enact your rescue plan, which often includes, calling someone to check on you or calling EMS. So both of these are virtual supervised consumption services for people who can't access a safe consumption site or don't have one in their community. And so oftentimes we'll get the question, okay, say we could do all this, but like, what if someone isn't interested in continuing on opioid agonist therapy after discharge? So if someone is, kind of in terms that we might use pre-contemplative, or they're not looking to make changes with their substance use as an outpatient, what's the benefit of starting them on methadone or Suboxone or Arcadian in hospital? Or what's the benefit of using such high doses of short-acting opioids if they're not going to continue on anything after they leave? And what we've seen in recent evidence is actually that maintaining opioid tolerance while in hospital is in itself a harm reduction measure to reduce the risk of overdose post-discharge. So this was from a study in England where they looked at the rates of overdose death sort of related to an acute hospitalization. And they found that the first 2 days after admission, the rates of an overdose death increased significantly with an odds ratio of 4.39. which decreased slightly sort of as you get further out from your admission. So day 3 to 14 after discharge, the odds ratio was about 2.09, but still remained elevated. And this is most likely attributed to the fact that when people are in hospital, often they have sort of an iatrogenic reduction in opioid tolerance, in that we underdose them on their opioids quite substantially. Sometimes with an intention to sort of get them off opioids, sometimes because we're just not comfortable prescribing the amounts that someone actually needs in order to maintain their tolerance. But this is actually doing them more harm, because when they leave hospital, if they resume their pre-hospital opioid use, the risk of an overdose in that first few days after they leave hospital is substantially higher. So even if it's just while they're in hospital, even if there's no intention for change in a substance use pattern after they leave, giving them those big doses of short-acting opioids to maintain their tolerance is absolutely the right thing to do and is very, very beneficial for your patient. So keeping that in mind when you're thinking about the doses, trying to wean someone off in hospital is very rarely the right time to do so. And then sort of mitigating the risk experienced by people who use opioids during and after hospitalization. So maintaining opioid tolerance is one point that we just went over, but there are other things that we can do to reduce the risk as well. Next slide, Tim. So we know that people who use opioids are at high risk of drug-related harms even while they're hospitalized. So in a Vancouver-based study, we saw that almost 44% of people who use drugs reported using non-prescribed drugs during their hospitalization. Oftentimes, because hospitals, including ours, have an abstinence-based policy related to drug use, these uses often include, going to the stairwell or a bathroom, or using outside, or trying to conceal their use from their healthcare team. This is where we sadly see people die of fatal overdose in hospital bathrooms or other places. But we know that it also increases their risk of their use because they're often using alone. They're often using unsafe equipment because there's not often access to safe drug use equipment in hospital. And then they're not given opportunities to have open discussions with their care providers around what they're using and any potential interactions with what they're receiving in hospital. So in terms of addressing that, so, addressing in-hospital substance use with a harm reduction approach is what we've been, practicing and what we hope to sort of have encoded into hospital policy moving forward. One small piece of that is making sure that we offer take-home naloxone kits at admission. So any person with any opioid prescription, in my opinion, should have a take-home naloxone kit, whether it's for their benefit or whether it's for the potential risk of someone consuming their opioid prescription accidentally who might be opioid naive. There's really no increased risk to having a naloxone kit at home. It's purely a safety blanket. So, having every single person given a take-home naloxone kit, it should be our practice, as well as providing safer use counseling and offering sterile drug use supplies within hospital, which I'll speak to further in a second. So we can skip over this one, Tim, because I think we spoke to this already. And needle and syringe programs in hospital are something that has been implemented at other hospitals, including Casey House in Toronto, and the Royal Alex Hospital in Alberta. Essentially what this is, and this is also something that we've been doing at St. Joe's over the last couple of years, is distributing sterile drug use supplies, including syringes, needles, cookers, sterile water, tourniquets, alcohol swabs, all the things that are distributed in needle and syringe programs across the country that have strong evidence for improving the safety of injection drug use, reducing the risk of HIV and hepatitis C, and also reducing the risk of injection-related infections. And we know that this can be done in hospital, and it provides both a patient benefit as well as a provider benefit, which I'll speak to on the next slide. So this is a quote that was in a study from Vancouver from a patient about why needle and syringe programs would be helpful. So they said speaking to the healthcare team, don't give rigs to us, which is a syringe. I think that they should. If not, we're reusing our rigs or we're having to risk getting kicked out for stealing them. So this is a question we get quite often in hospital is, should we be giving these supplies to people? Will it increase their risk of using drugs? And we actually know that it won't. The challenge is that if people don't have access to new clean supplies, what's often happening is they're going to be reusing the one needle that they came in with, or as something piecemeal that they could come across in hospital. They'll be trying to find a way to be able to use safely. And oftentimes that one needle that they have is going to be stored, in the pillowcase, in their bag, somewhere else. And that increases the risk of both needle stick injury from the healthcare team, as well as the risk of reusing a needle and the risk of infection for the patient. So having abundance of clean supplies, the only impact on the use is that it makes it safer, both for us as a healthcare team in terms of the risk of occupational exposure, but also for the patient. And then the next step, and something that we're hoping to move towards at St. Joe's, is having consumption and treatment spaces or safer injection spaces for people in hospital. So this is a place where people can go under a federal exemption to use non-prescribed illicit substances in a safe environment with monitoring, so that if someone experiences an overdose, they can be promptly treated. There have been cases where this has been implemented in hospital. And if you go to the next slide, Tim, when asked, a vast majority of people who use drugs will say that they would use a CTS in hospital if it were available to them. And we have one example from, again, the Royal Alex in Alberta, where they implemented a safe consumption space, which is pictured there, which was within the hospital, accessible to emergency level patients and inpatients. They felt that it was well accessed. There were no deaths within the space, despite sort of 27 presentations requiring a response. But they also found that they were able to trigger more referrals to the addiction medicine service. So it actually increased the uptake of treatment and other interventions because people were accessing a harm reduction space. And then finally, on the point of unplanned discharge, so we know that this happens very commonly among people who use drugs. So kind of between 25 and 30%, and our numbers in Hamilton are relatively similar. We know that often this is reported to be a response to either, hospital restrictions. So for example, not being allowed visitors, not being allowed to use drugs on the premises, difficulties in terms of the interactions with healthcare providers or interactions with security, and then very prominently inadequate pain withdrawal and craving management. But we also know that unplanned discharge itself is not a benign event. So there's a significantly higher rate of readmission in the 2 weeks after an unplanned discharge, and also a twofold increase in 30-day mortality rates, likely because people's primary medical condition that they came in for is not being adequately addressed. So, in terms of mitigating this risk, first thing we always do is just ask people what would make it easier for you to be able to stay in hospital. So, is there anything that we can do as a healthcare team, recognizing the constraints of the hospital environment, to make it feel okay for you to stay here? So sometimes that can be, providing resources for boredom or anxiety. So, coloring books, TV, something to do. Many of our patients don't have visitors frequently and don't have the resources to bring their own recreational supplies, and that can be usually helpful. Offering coffee cards or double meal trays for those who have had really, really, poor nutrition because they've been, outdoors or shelter-based. Talking about what would make it easier in terms of medications. What can we do for cravings, cravings for other substances like stimulants too? Is there anything we could do to make it easier to be here? And then having an unplanned discharge plan. So I remember in residency, someone on medicine, I'm sure, gave me the advice that on day 1 of admission, start planning for discharge. And I would say the same thing about an unplanned discharge. So as soon as someone's admitted, if they have risk factors for an unplanned discharge, which many of our patients do, start collaborating with them to come up with a plan in case of a premature discharge. So, contact information. Is there a way that we could get in touch with you? Do you access a specific pharmacy, a specific drop-in site, a shelter health clinic? Is there any other provider that you come in contact with that we could sort of use as a discharge plan if we needed one in a short-term kind of situation? Oftentimes we will arrange a preferred pharmacy and tell the patient that no matter if we were able to contact them before discharge or not, we will always send their prescription to that pharmacy so that they know that leaving hospital doesn't mean they're out of medications and they have no treatment plan. You can also use pharmacists as partners and, give messages to the patient for follow-up appointments or how to get back in touch or if there's availability for them to come back to hospital. And then making sure that any follow-up plan is low barrier. So, saying follow up with a cardiologist in 6 weeks and they'll call you. If that person doesn't have a phone number or an address, that plan's likely not going to work. So really making sure that the follow-up plan is rock solid and that the patient's aware of what they need to do so that whenever they leave hospital, they know that their care is going to continue. So I'm going to leave it there, I think, so we'll return to Lee. So, this is sort of our what if or our ideal scenario. So rather than Lee being discharged sort of as soon as her, level of consciousness improved, what if when her MRP assessed her in the morning, they talked about her substance use, they talked about her goals, and she was offered an admission for stabilization? Most patients would probably have never thought that this is a possibility. They might be apprehensive about it, they might be nervous, but perhaps the offer of being able to get to a therapeutic dose of methadone or Cadian, which has often been a huge challenge for many of our folks as outpatients, might be enough of a promise to kind of keep them in hospital. And perhaps by the time of a discharge, her methadone and Cadian will be managing her withdrawal and cravings, minimal use of short-acting opioids needed. Maybe we could get her a shelter bed and somewhere to follow up with and connect her to an actual follow-up plan that's going to work for her. Needless to say, this is probably going to increase our chances of a successful discharge plan than what we are typically doing day to day. And while it may not be sort of the only solution that we need to pursue to try to make a dent in overdose deaths, it certainly would be more than what we are currently doing and probably a more proportional response to the actual threat that our patients are experiencing day to day. So thank you for your time. Again, these are our 3 points, so I won't go over them again, and we're happy to distribute the slides, and we'd very much welcome questions.
Fantastic. Thank you so much. And if we were in person, you'd be no doubt hearing a large round of applause. Thank you so much for the compassionate and evidence-based approach that you've outlined for our audience today. And we'll now have about 15 minutes here for questions. So I'll start with the 2 questions that are in the chat, and then we've got a couple of hands raised. I'll encourage anybody else who has questions to follow either of those options. Either enter your question into the Q&A, or if you'd like to ask the question, happy to give you to allow you to unmute. So first we have from Dr. Jeremy Adams, any tips for providing procedural sedation for this patient population, for Dr. Adams as a cardiologist, for example, for a TEE? Any role for more anesthesia involvement for in-hospital procedures?
Yeah, I think anesthesia involvement could be very helpful for sure. To be honest, we are often not the ones doing the procedural sedation. So I think this is a question we can certainly follow up with our anesthesia colleagues to see what they have found most effective in our folks. But I will say that, sometimes we have seen a benefit from using adjuncts. So sometimes when kind of fentanyl infusions are not enough for our folks, anesthesia has used ketamine infusions, which has been quite helpful as well. So I think just following the principles of recognizing that tolerance will be quite significantly higher and then using higher doses as needed. But that's a great question. We're happy to follow up with you after we chat with our anesthesia colleagues.
Thanks so much for offering to do that. Next question here is from Dr. Amna Ahmed. Sorry, may have missed this. How to fill gaps in post-discharge care for patients with no phone or contact number? Yeah.
Tim, do you want to speak to that one? I saw you on mute.
Sure. Yeah. Thanks, Amna, for the question. I mean, I think this is a very common problem. And even if people have phones, oftentimes the number is quickly not valid because phones get stolen, phones get lost very frequently. So a couple of measures, like some which Robin mentioned already, but I think important, like Robin said, just to sort of start to address this right at the start. So most people will have a place that they are frequently visiting at the very least. So finding out where that is can be important, and then getting consent from the patient to be able to kind of reach out to that space if they're lost to follow up. In Hamilton, there's places like the Hub where people are dropping in very frequently. In the wintertime now, we've got different warming centers that people might be going to almost daily, or places they're going to get food or harm reduction supplies. There's often spots where people feel kind of safe and have a contact that you can reach out to. Many of our patients are involved with the social navigator program through the paramedics. So if they are involved with that program, it's an excellent resource because they're very, very available and quite helpful in terms of making sure people get to appointments. So again, establishing that with your patient, getting consent to talk to the social navigator, and then following up that way. And then oftentimes if people are on opioid substitution therapy, they're at their pharmacy every day. So that's another great resource, is knowing where their pharmacy is and then leaving a message for them at the pharmacy. Most of the pharmacists that we deal with are very, very happy to take that message. And then when the patient drops in, they'll let them use the phone at the clinic to call you back or to pass the message along. Those would be the main ways that I would go about it, Robin. I don't know if you have other things to add.
I think those are all great. And I think the last one would be for shelter-based folks is consider the Shelter Health Network. So the Shelter Health Network has clinicians at most of the main shelters in town. So if you just reach out to the general shelter health number, or if you go to the shelter health website, you can see which doctor is at which shelter on which day, and sort of looping them as a care provider, because they can always sort of take the initiative to talk to staff at the shelter to check to see if someone's come by and to sort of reconnect and follow up on any plan. Ideally with a warm handoff. Like I think, anything that's complicated, if you can try to get in touch with someone directly rather than, just sending a discharge summary, that's usually the best. It does tend to be, I think you do have to take a little bit more initiative, and it can be a bit resource intensive trying to do that, but it certainly is very, very worth doing.
Thank you both so much. And I've actually got a follow-up question. Some folks in the audience may not be familiar with the Social Navigator program or something like the Hub. Those are the two that stuck out from your answer, Tim. I wonder if you could give a little bit of background info about what those programs or services are.
Yeah, for sure. So the Social Navigator program is a partnership between the Hamilton Police Service, Hamilton Paramedics, and probably some other people. I think St. Joe's has a hand in it somewhere, to be honest with you. I think there's some partnership there as well. The folks that we deal with most are the paramedics, and so there's, I don't even know how many now, to be honest with you. At one point it was just one, but now there's several that are on the case, and patients will be matched to the program overall, but usually we'll have one paramedic that they are in contact with most frequently. And the matching can happen from referrals from the hospital as well. So if people aren't linked, definitely referrals can be made. And I don't know if there's a way, maybe we can share that in a newsletter or something, the contact information, so that people have that. And once they're matched with the program, then the social navigators will help them get to appointments. Like I mentioned, they'll pick them up at their encampment or their home or wherever they may be and drive them to appointments. They will help them with housing and get them linked to sort of housing programs as well. And I think very importantly, we'll kind of follow up with them if they're lost. So if they you know, are supposed to be somewhere and they're not the type of program that just kind of like discharges them from the program. They'll follow up until they find them. So a really excellent resource for sure in the community there. And then the hub is a drop-in program in Hamilton. So that it's on Vine Street in Hamilton. So it's a place where people can drop in. I don't have their hours on the top of my head, but they're open now in extended hours with the city's winter warming plan. And it is a place that many of our patients access for warmth, number one, but for food and kind of a safe place for them to be. Claire's popped the link in the chat there if people want to follow that.
That's excellent. Thank you so much. We've got Anne, who I'll invite you, and Dr. Anne Holbrook, with a question. Invite you to unmute, Anne.
Thanks, Madeline, and thanks very much for the talk. I just wanted to add some points as somebody who does medicine all the time, trying to deal with these patients. And I have to say that our substance use service has been invaluable in helping us with some of these very high opioid dose requiring patients. But there are a few issues that I think we should lay on the table that are kind of the elephant in the room. You know, as you know, medicine is charged with, we've got the biggest volume in hospital. We're charged by the hospital with getting patients in and out of the hospital as absolutely fast as we can. We're dealing with the immediate issue in medicine. Most of my colleagues are not familiar with you know, the evidence around dealing with this patient. So it's a huge problem. I think that there's a couple issues that we have. This is one of several problems the patient is presenting with. It's rarely the only problem. The problem of the addiction is very difficult to deal with. And in contrast to the comparison of heart failure or MI, this area is virtually free of randomized trials. So we don't actually have high quality guidance around what to do. Most of the evidence presented was retrospective, which is the best that we have, but we have to acknowledge the selection and adherence biases therein. Most patients have other addictions as well, which aren't amenable to the opioid agonist therapy. So, and they have, you know, largely mental health and huge psychological trauma issues, which I think a lot of us, even with the help of social work, feel our approach is really inadequate. So my question is sort of twofold. Where do you folks see the research headed? Pharmacologic replacement, I think, is never going to be enough. And we just put the rest of our community at risk with these enormous doses, you know, that are, you know, potentially prone to medication error. So where is the research headed? And what is your take, Tim and Robin, on the additional help of, you know, things that are really directed at psychological therapies or behavioral modification?
Thanks for that question. I think, absolutely. I think as you highlighted, right? I think these are some of our most, you know, medically complex, kind of less resourced groups of people, right? So I think that just goes further to support, you know, why we need to sort of challenge ourselves to go a bit further than we have done, because obviously, you know, if we saw that level of complexity and that risk in any other person, we'd be sort of scrambling to do everything we possibly could. And I think because of stigma, we so rarely are for this patient group. In terms of sort of where things are going moving forward, I think there is a challenge in doing, like you say, we, you know, Tim and I and Claire and a few others on this call from the Substance Use Service were very engaged in research. And I think one of the challenging things around structuring our research designs as an RCT is that so much in addiction medicine is sort of an emerging response to an emergency. And so when you sort of have something that is a potential a potential benefit to someone, it's very hard to do an RCT ethically, I think, as providers as well, and offer it to some and not to others. But I do see potential. So for example, I think, we could look at, if we become committed to offering admission for people following an opioid overdose, absolutely, we would want to study that rigorously to look at outcomes and impact following hospitalization. So I think that looking at the hospitalized care of people who use drugs is a huge area for research right now. In terms of sort of what do we do with the other resources, it's such a big question, right? Like, I think, yes, I would love if we had low barrier psychiatric care and counseling and social navigation and all of those things for every single person with this medical condition. I would also love if we had, a guaranteed basic income and housing policy that worked, and, all of those sort of structural things that we know are like, if we could give everyone housing after they left hospital, we would see probably the greatest benefit than we could from any possible pharmacologic intervention. So I think that's sort of the challenge, is sort of trying to practice in an area where you have enormous structural forces working against your patients, while also still remembering that we have the power to change what we do too. And so we need to use every tool to the maximum that we possibly can to try to make a difference for our folks. So I'll dovetail that to the question from Stephen Skitch in the chat, which is, it's a great message to consider admission for initiation of therapy for opioid use disorder if patients are willing. Is this an option? So I might put that out there to all of the internists in the chat and perhaps our chief as well. Is this something that we can commit to moving forward?
So Robin, the audience can't see Stephen's whole question here, but you read out the first part. So it says, speaking from an ER perspective, this question about initiation of therapy for opioid, I wasn't honestly aware that this is an option. Broadly speaking, is there consensus among the IM group and that is there consensus among the IM group that these admissions are in scope / reasonable? Certainly wasn't common practice when I trained in residency, finished 5 years ago. It's a really good question, and I think it does fit in with Dr. Holbrook's, question. It's very unfortunate timing in one way, because we've got all of this hallway medicine going on, and just with the patients coming in with other presentations and other needs for admission. But I think you've spoken to it well, in the sense of, does that necessarily mean that we deprioritize these people with similarly and sometimes more life-limiting issues? So it's maybe a question for some more reflection within the GIM group, and I think you've certainly started an excellent dialogue here. And I see there's lots going on in the chat. Including a nice response that you've provided to Stephanie's question. All right, so Tim, did you want to add to that?
Maybe just very quickly, I was just going to say again, just back to Dr. Holbrook's question, which is very it's very valid, I think. Especially if you're looking at patients who are, let's say coming in from an encampment or something like that with an opioid use disorder. The idea that just opioid agonist therapy is going to fix everything is naive for sure. And a lot has to break the right way for that to work out well in terms of like what's available today in the community. So I think there's two pieces of this. I think there's recognizing that the opioid agonist therapy can be life-saving. We need a lot of extra resources in the community. But even having said that, Robin and I and others on this call have seen this actually work, right? Where patients have been, there was a patient in our clinic on Tuesday who had been in the emergency room lying in a chair after, being in PES, and the idea was that she was going to get discharged, and we advocated for her to stay in hospital a couple of days, and she's a year off of substances now. She's housed, she's doing well. So it's possible and it can happen. And I think the piece is that opioid agonist therapy is a key piece to that, which we can control here in the hospital side. And definitely I think it's important, as Dr. Holbrook mentioned, that's, it's a piece to it. There's lots else as well for us to work on.
Fantastic. And Robin, I saw you responding to Stephanie's question about drug paraphernalia and harm reduction approach in the hospital, and you've made reference to the policy updates. I'm thinking that might be a great update for you to spend a moment speaking to before we wrap things up.
Sure. So yeah, so since 2018, we've been working on sort of adapting our approach hospital-wide to be more harm reduction focused. And so we will likely, be presenting this policy for feedback, I think probably in the next few months, because it is going through all the sort of necessary committees at this time. But essentially, what to do as like what would we do when we see someone with kind of harm reduction equipment or kind of paraphernalia with them. So I think first thing to do is just sort of have that conversation. I think having an open discussion with people about their use is the most important. So asking them, and probably the key question we can ask is, what is your non-prescribed substance doing for you? And is there anything that we could do with our prescribed medications to help with that symptom instead? So most often it's withdrawal, cravings, or pain. And they were, too afraid or didn't realize that they could ask for more medications or a different option. So saying, we would love to use all the resources at our disposal to manage those symptoms for you. Would you be willing to kind of work with us to develop a plan that might work better so you don't need to use anything non-prescribed? I think that's number one. I think number two is making sure that they know that they have access to ongoing safe drug use equipment. And at St. Joe's, you can do that by referring to the capacity building team, and they will bring someone safe injection supplies or safe inhalation supplies. And then I think the third point would just be making sure that they have naloxone kits available. And then the fourth would be avoiding any undue security involvement. So many of our folks have been incarcerated in the past or have lots of interactions with security personnel in the community that can be stigmatizing. So we would reduce the use of security so that, someone using non-prescribed substances, in our opinion, should not be a requisite for security involvement or involuntary search or anything like that. Asking someone to, store their supplies in somewhere safe so that it's not sort of out and about in the room, and we can provide lock boxes if needed, and then only using security personnel if there's a concern for safety. So for example, weapons or something like that, which truthfully, I've never actually encountered with any of our patients on this service since 2018. So just something to keep in mind. And the last thing I just wanted to end with was a thank you to all of our medicine colleagues, because, we started our service back in 2018 and it's been, a few years now. And we always say this, and it's true, that medicine has been our greatest ally in terms of being really open to keeping our patients in hospital so that they can complete their titration of their opioid agonist therapy, so that we can come up with a good discharge plan, and really recognizing sort of substance use as a significant concern on the list of issues during hospital. So thank you for that, and we appreciate your partnership in this.
Fantastic. Thank you. There was one last question from Dr. Holbrook that I've cut and pasted. It's going to come to you in an email so you can follow up with her. There's a question about, will this be posted somewhere? And thank you for that. This is being recorded and will be posted on the Department of Medicine YouTube channel. It's usually up within a week or two. If you just Google it or search on YouTube, you'll find it quite easily. I want to again thank Drs. Lennox and O'Shea today for a fantastic talk and a really thoughtful discussion at the end. Thanks to all our attendees and those who brought forward questions and discussion. Shout out to Dr. Bodkin for all of her contributions in the chat there. And we'll see everybody back for rounds next week at noon, January 18th. HHS will be the host site, and it will be Dr. Haroon Yusuf giving us an update about the acute hospitalist medicine service. So that should be very interesting. Wishing you all an excellent rest of your day and a wonderful week. Take care.